So, madam, whenever you feel like, I think you can start.
Just wait for 1 more minute and we'll start.
Okay. Sure.
Shall we start?
Yes.
So, good evening. So, I would like to welcome all of you for the 5th debate session of controversies in neurology. And today we have a very interesting debate, and I'm sure we are going to have a some form of a consensus at the end of this 1 hour session. Let me welcome our expert panelist, Dr. Subhash Kaur, who is a senior consultant neurologist, KIMS Hospital, Hyderabad. Dr. Subhash Kaur doesn't need any introduction to this audience. Dr. Gigi Kurutulam, who is a senior interventional neurologist from Rajagiri Hospital, Kochi. Speakers who are going to be giving you an overview of whether we should really go about doing mechanical thrombectomy in our patients with large core or not. We have Dr. Bobby Workey, who is a senior consultant interventional neurologist at Aster Medicity, Kochi, and Dr. Piyush Oja from Fortis Hospital, Gurgaon. So, today for the session, we know that endovascular thrombectomy is a very important mode of treatment, and the patients are likely to really benefit from this treatment, and the number needed to treat in patients who have a thrombectomy in the first 6 hours is 2.6. The current RCTs which has come out with regard to the large core thrombectomy has made us all think about doing endovascular thrombectomy for patients with a larger core, especially in the patients with an aspects of 3 to 5. So today, we know that there are a lot of challenges in these patients who are not the really good patients for thrombectomy, but we still know that there is a lot of patients who are still likely to benefit. So today for this session, we'll be discussing on whether endovascular thrombectomy should be only for a select group of patients, or it should be done for all patients with large core. So let me just invite Dr. Bobby Workey to talk for large core thrombectomy in patients with acute ischemic stroke. Over to Bob.
Thank you. So, madam, initially we'll have a poll. That's what I think our format.
Ah, yes, I forgot. Yes, yes. Yes,
so,
we have the poll.
the admin team, can we share that poll question?
So first, before that, we are going to have this poll. Please put your vote and then we'll have the session.
So this is the question. Endovascular thrombectomy should be done in all the patients with large core infarct. Option 1 is yes, option 2 is no, and option 3 should be done. Why there should be a debate about this, and fourth one is what is a large core. So there may be question like a neurologist like me, what do you mean by large core? So I took the liberty to format this question.
So we can vote.
No,
panelists will be
host and panelists cannot vote.
Oh, okay.
Okay, so I request all the delegates to vote and then. Okay, so we can show the results maybe now.
Okay.
Okay, so there are people like me who tells that what is a large core, what do you mean by? So I think probably first that needs to be defined, what is the large core, and subsequently I think equally divided house, yes and no.
Yes. Okay, so now we can have Dr. Bobby.
Thank you for the opportunity. My talk is on endovascular thrombectomy should be performed in all patients with large core. So, first of all, I'd like to define for those people who do not know what a large core is. There's a lot of volumetric measurements that have been done on the brain, and we know that the approximate total volume of the cerebral contents is about 1,200 cc, of which the MCA alone forms about 300 cc on each side. So traditionally, in mechanical thrombectomy, we have used either the CT perfusion core volume or a diffusion weighted MRI to define as a volume of about 70 cc or an aspects of less than 6, which has been excluded from most of the initial trials. And by convention, what we mean by a large ischemic core is an aspects less than 5 or a CTP core volume, which is more than 50 cc. So this is what the cerebral volumetry looks like when you draw cursor around and you just like you calculate the volume in intracerebral hemorrhage, it's ABC by 2, and you can see that the ACA forms about 140 cc. The middle cerebral artery forms about 300 cc on each side. The posterior cerebral artery contributes to about 120 cc. Now, if you find it difficult to actually go through just like ICH, go through each of the sections and calculate the volume, you can even do an eyeballing method. So with this eyeballing method, which is a simple visual tool, you can see that you can make out just by looking at the MRI or the CT, you can estimate approximately what is core volume less than, say, about 21 cc. What is a core volume of around 31 cc? And this is what a core volume about 51 cc will look like on a CT or an MRI. It's a simple visual tool for decision making. Now, 2015 was the big year in stroke when suddenly a lot of therapeutic nihilism disappeared, and back-to-back 5 major trials came into came and influenced our clinical practice, which showed the benefit of endovascular thrombectomy and mechanical thrombectomy in selected patients up to 6 hours with large vessel occlusion, especially in the anterior circulation, and these were the Mr. Clean, the Escape, Swift Prime, Extend IA, and the Revascat trials. So for about 8 years or 9 years, we were kind of very selective in the patients that we would do mechanical thrombectomy on. But again, in the last, say, 1 year, 3 new trials have again made their entry into the scene. One is the Japanese trial, one is a Chinese trial, and one is a multi-center trial. All 3 are published in NEJM. And these all took up the task of looking at how patients with large ischemic cores or large infarcts perform after endovascular. So if you look at the first one, that is the rescue limit Japan study in 2022, you can see that the time window was shifted to about 24 hours. And also the aspects, you can see the aspect score that they have looked at is an aspect score of 3 to 5. They have taken patients with an NIH score of greater than 6. And they have predominantly looked at the ICA and M1 LVO. And they found that even patients with large cerebral infarctions up to 24 hours had better functional outcomes with mechanical thrombectomy as compared to less medical therapy, with a risk ratio, odds ratio of about 1.85, that is at about 3 months. But there was some more incidence of intracerebral hemorrhage in these patients. The next trial was there's another major trial that was the SELECT2 trial, again, which came out in 2023, which again looked at the period of about 24 hours with a core of greater than 50 cc on CT perfusion or diffusion weighted MRI. And again, here they found that up to 24 hours, mechanical thrombectomy may be feasible. Of course, expectations need to be realistic, as all patients with very low aspects or large core patients may not do very well. We look at these trials a little bit more closely and how they can influence our practice. The third trial is the Chinese trial or the Angel aspect trial. Again, CTP core here, they used an even bigger core with about 70 to 100 ml, and even with an aspects of 0 to 2. And they still found that there were better outcomes with mechanical thrombectomy within 24 hours as compared to best medical therapy alone with odds ratio 1.37. But of course, these patients had a significantly more ICH compared to the best medical therapy. So if you look at the rescue limb in Japan, you can see that where the number of patients in both groups were equally matched, but a significant number of patients more had endovascular form achieved more or better modified Rackett's scores at 90 days as compared to those with the received medical care. Now, the highlights of this therapy were that these patients were very.
Bobby, can I interrupt? It is in
Yes.
between breaking. I don't
Okay.
know whether it's only for me.
Everybody hear me?
Intermittently, Bobby says it is bit breaking, but that is now we can hear you. Probably if you can shift it slightly forward, I think that.
So the highlights of this trial was that
This
these
is better.
patients had a very high median NIH score of 22. They had significant large vessel occlusions in the IC or M1. But one of the main problems with this therapy was as compared to even medical care therapy in Japan, they use a much lower dose of RTPA. There's the much lesser incidence of patients were given RTPA, and they use conventionally a lower dose of RTPA than we use, that is 0.9 milligrams per kilogram. But you can see that even though the intracranial hemorrhage was significantly higher within 48 hours, at about 58% as compared to the medical group, these patients did do okay in the sense that they underwent, they had lesser incidence of recurrent cerebral infarction within 90 days, as well as probably a lesser incidence of decompressive craniectomy within 7 days. So overall, this was kind of showed that probably late strokes or patients with large core infarcts could possibly be taken up for endovascular therapy. Now, when we look at the Angel Aspects trial, here again, you can see that the MRS is shifted towards a lower score in patients who underwent endovascular therapy as compared to medical management. And the highlights of this trial was that you can see that significant number of patients achieved an MRS of 0 to 2. That is almost 30% as compared to patients who underwent, who received only medical therapy, which is only 11.6. And even a modified Racket score of up to 3 at 90 days, this was significantly higher at 47% as compared to 33%. And when you deal with stroke, you know that you're providing the best treatment upfront, though there are significant costs upfront. It is in many patients a long process that takes a few weeks to months for them to improve. So even though you may not find immediate recovery after endovascular therapy, the trials obviously show that as you go down the road at about 2 to 3 months, there is a significant improvement in the modified Rankin score, functional independence, and ambulatory scores after mechanical thrombectomy. And you can see that even the symptomatic ICH within 48 hours, though it was slightly higher, it is not as high as we expect in the days when we used to previously use alteplase for our patients. The rates of symptomatic hemorrhage are more or less comparable to that. So that's a significant advantage, or probably some a reason that we can use to extend the therapy to these patients. So again, the outcomes or the conclusion of this trial was that patients with large vessel occlusions, the anterior circulation, endovascular therapy within 24 hours can possibly result in better functional outcomes at 90 days. Now, if you looked at the SELECT-2 trial, again, this also showed a trend towards better improvement in lower MRS scores in patients who received just best medical care. And you can see that here, these people used a much larger ischemic core. The median estimated ischemic core volume was almost about 80 ml. Though only 20% of patients received IV thrombolysis, even then, in that case, doing EVT showed a significant improvement in secondary endpoints such as functional independence at 90 days, almost 20% compared to 7% in the BMT group, as well as independent ambulation of about nearly 38% as compared to about 90%, almost twice that of the patients who received best medical care. So the conclusions of this trial, again, though, whether there was not much symptomatic ICH within 24 hours. You can see that it is only about 0.6%. It's probably even less than the best medical care patient. So this trial also was terminated early because of the dramatic increase or improvement in functional outcome of the patients who received EVT as compared to just West medical care alone. So if you do a forest plot of all these three major trials, you can see that these trials do show that the primary and secondary outcomes are definitely favorable for thrombectomy as compared to West medical therapy. And also you can see that if you look at the intracranial hemorrhage, overall, although there is some amount of evidence in one trial that favors medical treatment, and there is in all the other big trials, there's more numbers, and the overall trend shows that intracranial hemorrhage is not a big problem with EVT, even in large co-patients. So the combined analysis of all these trials within the last 24 hours, within 24 hours of last C12, confirms that the benefit of thrombectomy in terms of 90-day MRS improvement and independent ambulation is definitely weighted in favor of EVT versus best medical management. And the safety of EVT in this population has been demonstrated by the fact that there is no significant difference in the proportions of symptomatic ICH or mortality due to the procedure. So although the 2015 trials provided the first high-level evidence supporting the use of EVT in selected patients with anterior circulation LVO within 6 hours, the newer studies definitely show that there is some evidence for benefit of ET or medical management for patients with large core without increased risk of symptomatic ICH or adverse events. So the overall consensus now seems to be that just based on perfusion imaging or just based on initial assessment of the patient with high NIHs or low aspects of 3 to 5, EVT should not be withheld, and EVT should potentially be offered to the patients. But however, we know that this is not the case in the sense that all patients with large core cannot be taken up. If the core is more than 100 ml, definitely that is more than, say, a third of the MCA territory. In that case, then it's very unlikely to show any benefit, as shown by the secondary analysis of the SELECT study. So probably between 50 to 100 ml is the sweet spot of patients who are going to benefit from EVT. So this is just a diagram that shows you different ways of measuring the CTP or the CT volume of infarction, and best place to just draw a cursor along the outline of the infarct and take the number of slices thickness as you would do in cerebral hemorrhage, and that is probably the most accurate, calculating A, B, C by 2. Now, in posterior circulation, there are no comparable trials because unlike the anterior circulation strokes where NIH score of greater than 6 is recommended for EVT, and there is a specific infarct core volume which has been defined, the RCTs for posterior circulation do not most of the time have an infarct volume criteria. So in this case, it is kind of paradoxical that patients, when they looked at patients in the basics cohort, they found that patients with who had mild to moderate deficits, their risk of death or dependence increased by about 20% with EVT. This may be because of distal migration of the clot or a poor collateralization of the posterior circular villus. So probably patients who have very low NIHS score in the posterior circulation may benefit more than patients who have adequate collateralization at the level of the circular villus and who have low NIHS scores. And paradoxically, these patients also, the worse off patients are more likely to benefit than patients with low NIHS scores. So high NIHS score is generally not considered a contraindication to EVT in the posterior circulation. And even in the basilar registry, there was a 5-fold increase in the likelihood of achieving a favorable functional outcome at 90 days for severe posterior basilar artery occlusion within NIHs of greater than 21. Again, there are some pointers which can tell you which patients to select. Overall, an infarct of more than 10 cc the diffusion weighted MRI or 10 cc localized the brainstem is a predictor of poor outcome. In the posterior circulation, in the medulla approximately corresponds, the volume of the medulla approximately corresponds to about 3.5 cc. The volume of the pons corresponds to about 12 cc, and that of the midbrain corresponds to about 5 to 6 cc, making up for a total of about 22 cc. So you can see that if about 10 cc or nearly half of the brainstem is infarcted, or the one cerebellar hemisphere, which approximates about 100 to 100 cc. Out of that, if the cerebellum is probably less eloquent than the brainstem. So if the brainstem is selectively involved, these patients may not benefit as much as even if a large portion of the cerebellum is infarcted or shows a PC aspect score of less than 6. So again, these are some of the trials in the posterior circulation which have come out. The Baroness trial, which came out recently, the Baoshi trial, Attention trial. And I'll talk only about these 3 trials because these are the ones that predominantly looked at severe posterior circulation strokes, though I know that it doesn't fall within the gamut of this discussion because we are talking about large core. Still, these patients are comparable to the large core anterior circulation strokes because they have a very huge NIH score and they have a significant amount of lag to treatment time up to 24 hours in some cases. But even then, most of these trials showed a trend towards a good functional outcome. That is an MRS score of about 0 to 3, which is about 2-fold greater in the EVT group than in the best medical treatment group, which is much better than what we can offer medically in these. Thank you.
So thank you, Dr. Bobby. So that was a very good debate. And now we will go to Dr. Piyush. Piyush will be talking on endovascular thrombectomy should not be done for all large core patients. Over to Dr. Piyush.
Good evening, everyone. Thank you so much for the opportunity. Am I audible, ma'am?
Yes,
Hello?
yes. Yes, yes.
Okay. So, thank you so much, Dr. Bobby. I think you have covered majority of the discussion that I'll be covering, but I would say that I agree but disagree, right? And as Dr. Kaul was saying that an interventionist should talk about what are the possible indications where thrombectomy should not be done. So it has, I had to really think a lot about what are the indications. Probably I will not offer this, or I'll think twice before offering the treatment. Okay, so coming about in a patients with acute ischemic stroke with large vessel occlusion, what is our main goal? So our aim is to achieve reperfusion and not just simply recanalization. It is to be done as early as possible, and we should have maximum reperfusion, that is TICI grade or 2B or 3. So this is just for the audience that because there will be a lot of discussions in my talk about MRS and TICI score. So MRS, we all know it's from 0 to 6, with the grade 6 being a patient is dead, 0 being no deficits at all. Most of the trials, they talk about the patient's outcome in terms of MRS 0 to 2 or MRS 0 to 3. And then when we talk about TICI score, it is the score that is used to assess the recanalization in a blocked artery in a major vessel occlusion, whether it is mostly in cases with mechanical thrombectomy, but can also be used in certain cases where IV thrombolysis opens up the vessel. So few terms before I go into my main talk. So what is successful reperfusion? So successful reperfusion is defined as a TICI grade 2B or 3. By functional independence, we mean that a patient is able to achieve an MRS of 0 to 2 at the end of 90 days. By saying good reperfusion in a patient who had an LVO, who achieved a successful reperfusion with EVT and also achieved in functional independence, that is an MRS of 0 to 2. But there is also something called as futile reperfusion. Futile reperfusion are those patients who had an LVO, had a successful reperfusion, but they did not achieve functional independence. So large core by definition, they are defined as patients, as Dr. Bobby said, the patients who had in a non-contrast CT with an aspects of less than 6. In patients who undergo CT perfusion or an MRI, there are different trials, they have used different criteria. Some studies have used 50 ml as the criteria. Some studies have used 70 ml. So this is the index case around which my entire talk would be based. So this is a patient, middle-aged male with a 5 hours duration. You can see there is a large infarct already settling in the non-contrast CT. Aspect would be around 3 to 4. And then it is also matching with the CT perfusion. So the treatment that would be offered to this particular patient has evolved over the last many years, whether we talk about pre-2015 era, after 2015 to 2019, after 2019 till majority of the trials, like 3 major trials of anti-circulation that have come, and what my perception is. So I'll be talking about that in the detail. One more word, I'll be also covering what the trials say, but trials are done many times in scenarios which are ideal, like in well-established circumstances, but patients do not fall into many those circumstances. So I'll be also considering what we can consider in real world scenario. So we've seen this slide many a time. So this is from the Hermes data. We know that endovascular thrombectomy has proven its benefit across all the strata, but there was no difference in mortality at 90 days of symptomatic ICH between the two groups. But the Hermes data, or whatever the trials that were undertaken before that, they did not include large stroke patients. These patients account for almost 1/5 of all the LVO patients, whether you do an NCCT or a CT perfusion or an MRI, and they all have been underreported in thrombectomy trials. So we do not have sufficient data. Let me just talk about few of the studies which also might be an important factor when we talk about the treatment plan. So this is another study where which actually analyzed the importance of various factors in a patient who undergo recanalization in acute ischemic stroke. But since this was done in 2010, it talks about intra-arterial thrombolysis. When we look at the various factors, which actually gives us an idea about what are the factors which might affect the long-term outcome, good outcome in these patients. So patients whose age was more than 70 years, in a patients who had a high NIH score, in other terms, they had a large infarct or a large core, or when there was a time more than 3 years, those patients did not have a good chance of achieving a good functional outcome. Then this was a recent study which was published, and it gave us an multiple independent predictors of futile reperfusion. So again, if you see patients whose age was more than 69 years compared to less than that, they did not have a good chance of good functional outcome. Besides that, high NIHs, baseline aspects, they took baseline aspects of like less than 8 and more than 8. So patients who had a low aspects of 8 compared to high aspects, they did not have a good chance of achieving a good functional outcome. And also the patients whom were shifted to a center by drip and shift method compared to the patients who were treated in the same center with IV thrombolysis and mechanical thrombectomy. So the patients who had a drip and shift model, they had a poor chance of achieving a good functional outcome compared to the mothership model. And also like the general anesthesia factor and the patients who did not achieve a complete reperfusion. This is also a very interesting study, which was again from the Calgary group by Dr. Vivek Nambiar. He was the first author in this. So this study looked at the association between recanalization after intra-arterial therapy and favorable clinical response, and whether it was modified by looking at the presence of collaterals on the baseline CT angiography. Since there was no aspiration devices or stent retrievers, they were not frequently used at that era. So they use intra-arterial therapy, which could be intra-arterial urokinase or balloon angioplasty or simple wire or microcatheter manipulation using GP2B3 inhibitors. And also there were certain patients in whom off-label stent placement, which was predominantly coronary stents, were used. So when you look at the collateral status, you're looking at the patients, they were divided into 3 categories. So patients who had good collateral score, intermediate and poor collaterals. Patients who had poor collaterals, they had a high NHS and low aspects. Also, they had a high baseline infarct volume. And again, they have a higher chances of infarct growth over the next 24 hours compared to the patients who had a good collateral and intermediate collaterals. When they analyzed the mean baseline infarct volume and infarct growth over the next 24 hours in patients who were offered endovascular treatment, there were significant difference in the patients in terms of infarct growth. In good collaterals, there was very less of infarct growth compared to intermediate and poor collaterals. However, in the patients who were non-recanalizers, there was no significant difference among good collaterals, intermediate collaterals, or poor collaterals, just highlighting the importance of the collaterals. Now they further went and formed a common group of the patients who had good and intermediate collaterals. So only the group of good and intermediate collaterals who were good recanalizers, they had a higher chances of achieving a good functional outcome. But the patients who were non-recanalizers, they did not. When we talk about poor collaterals, whether they were able to achieve a good recanalization or they were non-recanalization, they were not achieving or they were not correlated with a good functional outcome at the end of 90 days. This is the same thing that the patients who had a poor collateral, whether it was non-recanalizers or recanalizers, and patients with intermediate and good collaterals, only non-recanalizers, they were not able to achieve a good clinical outcome at the end of 90 days. So collateral status, it correlates with baseline infarct volume and infarct growth over 24 hours. Good and intermediate collaterals with intra-arterial therapy do better than recanalized. The study also shows that the rate of infarct growth is quicker in intermediate collaterals, and they only benefit if they are treated early. But patients with poor collateral status, they are fast progressors, or the infarct growth is quickest, and they do not do well even if recanalization is achieved with intra-arterial therapy. Again, this was a meta-analysis of all the patients from the 7 big trials from the Hermes group. We can also again see that the patients who had poor collaterals, they did not have a good functional outcome. And although it did not match with the aspects of 0 to 4, although they were underrepresented in this particular study group, as already discussed. When we again divide the patients between 0 to 2 and 3 to 5 and 6 to 10 of aspect score, they were underrepresented, and there were 11 patients with aspect 0 to 2 in mechanical thrombectomy plus best medical management, and none of those patients achieved functional independence. This is again the same representation, that aspect 0 to 4. In terms of mortality, it was non-significant. When we talk about intracerebral hemorrhage, again, there was no significant difference among different aspect groups. Talking about the symptomatic intracranial hemorrhage, there was a high chance of symptomatic intracranial hemorrhage in patients who had endovascular thrombectomy, but it was not in the control group, although it was, and it was clinically significant. When you talk about the presence of cerebral edema in patients who had a large hemispheric infarct undergoing reperfusion treatment, if there is a large core volume, which is more than 130, or CT aspects of less than 3, there is a high chance of increase in cerebral edema compared to the control patients who were not offered mechanical thrombectomy. Now, all these studies led to the formation of these guidelines in 2019, which tells you that in selected patients with aspect more than 6, there is a class 1A evidence, but aspects less than 6, there is 2B evidence. And this was the reason, as till then, majority of their studies which were published till then, they had all these patients in which we are trying to discuss, they were underrepresented or they were not included in those studies. So this was another study in which they started analyzing whatever the studies that were available till that point of time with aspect less than 6. So as per the results, almost 22.1% of the patients with aspect 4 were functionally independent, which again dropped to 13.9% when the aspect 0 to 3 was considered. So if you look at the overall analysis, the patients were able to achieve a good functional outcome with compared to mechanical thrombectomy, but when you divide it into further aspect groups, it decreases. Like when you talk about aspect of 6, almost 37% of the patient achieve MRS of 0 to 2, which decreases to 33% in aspect of 5, but it drastically drops to 17% in patient with aspect 4 or less. When we divide it between aspect of 4 and aspect 0 to 3, again, there's a difference of 22%. Majority of the patients with aspect 4, they do relatively well among the group. But in aspect 0 to 3, only 13.9% of the patients were able to achieve an MRS of 0 to 2 at the end of 3 months. This is again the similar results. When we talk about the age factor, so patients who are younger than 70 years of age, the chances of achieving a good functional outcome is around 40.3%, but in patients more than 70 years of age, it drops to 16.2%. So the study, this particular study, it had its own limitation because out of all the studies that were analyzed, only 2 were randomized trials and the rest of the study was observational data only. Then we come to the next part, which are the recent published study, as Dr. Bobby has already discussed, the rescue JAMA limit. But when we look at the eligibility criteria of this study, so among all the 3 studies, one of the inclusion criteria is that the patient should have a baseline MRS of 0 to 1, aspect 3 to 5. And as Dr. Bobby said, the alteplase dose was lower, as already discussed. The patients in whom endovascular therapy was done, they had a high chance of achieving a good functional outcome compared to the medical group. But when we talk about MRS of 0 to 2, only 14% of the patients were able to achieve MRS of 0 to 2, which was only 7.8% the medical care group. In terms of symptomatic intracranial hemorrhage, there was no difference in both the groups. But if you look at any intracranial hemorrhage, it was significantly higher in endovascular treatment compared to the medical care group. So this was the first positive RCT, which actually gave us an idea that endovascular therapy is helpful in patients with aspect of less than 6. This was again published in 2022, which analyzed or which gave us an idea about all the trials which were undergoing that time with large core. So if you look at the aspects, so most of the studies, they had an aspect of either 2 to 5 or 3 to 5 as the inclusion criteria. Age, talking about, only one of the study has an upper age of 85. Otherwise, the patients were mostly patients for less than 80 years of age. Coming to the second study, which was Angel aspects, it was again, patients inclusion was 18 to 80 years and aspect score was 3 to 5 if only on NCCT. But if you include perfusion, there were patients of more than 0 to 5 aspects were also included. We already discussed that there was a good clinical outcome in patients with endovascular treatment compared to medical group. But if you look at the safety outcomes, so there was a high incidence of intracranial hemorrhage in patients with endovascular treatment compared to the medical management. High incidence of any intracranial hemorrhage compared to the medical management group. But there was no difference in death in either of the 2 groups. It was 21.7% in endovascular treatment and 20% in medical management group. There was no difference in the rates of decompressive hemicranectomy among either of the 2 groups. When you look at the pre-specified subgroups, again, the patients who were more than 75 years of age, they did not do well compared to the younger patients of less than 75. Patients in whom the treatment was offered early, which was less than 6 years of age, the result was not significant. Maybe they were fast progressors. Patients who had a high NIHs of more than 16, it was not significant. Aspects of less than 3, again, it was not significant. And patients who had a large infarct core or more than 70 ml, again, it was not significant. So the conclusion of the study was the patients with large cerebral infarction had a better outcome, but had more intracranial hemorrhages. Coming to the third study, which was SELECT2 trial. The patient inclusion criteria was 18 to 85 years with aspect 3 to 5. Core volume was more than or equal to 50. But again, baseline pre-MRS was 0 to 1. When we talk about the shift in modified Rankin score, endovascular therapy group favored better compared to the medical care group. But again, if you look at the MRS 0 to 2, functional independence was better in endovascular treatment. Successful reperfusion was better in endovascular treatment. But if you talk about the early neurological worsening, it was more in patient who had endovascular treatment compared to the medical management group. Maybe it was, and that was the reason they had poor functional outcome. Again, the subgroup analysis, patients who were more than 70 years of age didn't do well compared to the younger patient. Patient who had an ICA occlusion didn't do well compared to the MC occlusion. And again, low aspects didn't do well compared to the other aspects pre-specified criteria. So when we look at all the current data available in anterior circulation with large vessel occlusion, where do we stand? So in an ideal world or circumstances, as we talk about the trials available, we either have a negative data or a no data or insufficient data for patients with large vessel occlusion with a large core. If there is a pre-morbid MRS of more than 1, if the age of the patient is more than 70, if the patient has poor collaterals, if the patient has an aspect of 0 to 2 compared to the patients with aspect 3 to 5, and we still do not have good sufficient data with large vessel occlusions and large core in posterior circulation stroke patients. But there is a difference between ideal world and a real world. So ideal is, the word ideal is based on suitability, but real is based on originality. So if this was me, when I look at the mirror, I think I'm perfect, but in real, I'm not. So now let's come to the real world. Let's get out of the trial data and come to the real world. So this is one of the paper I found, which was Shalja ma'am was one of the authors. So it tells you what is the cost of stroke treatment in the patients in India. So for patients, for first 6 months of admission, the cost in government setup, in a tertiary level, government hospital is something around 20,000, which significantly increases to almost 1 lakh in a private tertiary stroke center. If you look at the median cost for a period of 12 months, it is huge. Now, before concluding my talk, I'll just share multiple scenarios that we can relate to in our daily lives. So first scenario is, there's a 50-year-old wealthy businessman. He's living in a metro city. He reaches the ER of a fully equipped tertiary stroke center within 1 hour. His non-contrast CT is done within 30 minutes of arrival. He receives TPA. Family is offered TPA. They take it. Now then, considering a large core, they are also offered EVT. They have been counseled that the chances of a good functional outcome, we are not sure. We tell them the data that we have from the studies, and we clearly explain them the long-term recovery. Family has no issues. They go ahead and give consent. Let's come to scenario number 2. There's a 45-year-old shopkeeper living in a metro city. He has a sudden onset of hemiplegia. Somehow the family hires a cab and reaches a small hospital, which is a primary stroke center. They reach there, the CT head is done in 1 hour. Family then is counseled for IV TPA. Before giving the consent, they take their own time. They call multiple people and they finally give consent. Now, finally, doesn't help, IV TPA doesn't help, and then you counsel them for EVT. But family denies due to financial constraints. And the only question they ask you is, will he be able to go back to shop after the procedure? And if yes, when? And frankly, I don't have a clear answer to this particular question. Coming to the scenario number 3. There's a 50-year-old, he lives in a remote village. He develops left side weakness. Family goes to a local quack, gives some traditional treatment. Patient worsens next day. Attendants then bring him to a nearby government hospital. And after there, the CT head is done after 5 hours because there is a long waiting for the patients. CT head shows an already established infarct. The family continues treatment for 2 days, no relief, and then they take it to the nearest religious healer. So the reason that I've told you these three scenarios is this is the current practical situation that we face daily in our daily lives. So what are the challenges that we face in our healthcare sector when we deal with such patients? We all know that there are very few centers who are stroke ready hospitals, but they are mostly private hospitals. Usually the patients are referred from some other center. They initially go to some primary stroke center, which gives IV TPA if it is available there. And then they are referred for endovascular thrombectomy at a tertiary stroke center. So important, crucial time is lost. Not all people can afford the cost of EVT. So if you're telling a family, okay, so this is the procedure that we are probably going to do, this is the risk, they sometimes, pay everything they have and they go under financial burden before taking the decision for EVT. If they decide, the family expectations are very high, even if you counsel them everything. Many times they say, we are paying and we want results, for which you don't have any answer. For family, it is very difficult to understand the long-term recovery in acute settings. It is very difficult for the family to be counseled regarding the futile recanalization factor. Post-EVT cost in a private setup is again very high. And once financially burdened during the acute part, long-term rehabilitation suffers. And many times the patient himself is the sole bread earner. So this was just a brief description about the real challenges that we face when we deal with such kind of patients. So my conclusion for this particular topic is, so mechanical thrombectomy, we know it is the standard of care in acute stroke patients. For patients with aspect of more than or equal to 6, there is no doubts about the efficacy. Aspect 3 to 6, we have sufficient data about efficacy on long-term outcome. Further data is still accumulating. We either have negative data or an insufficient data or an underrepresented data in certain set of population, for which we should be very careful, especially aspects of 0 to 2. If the pre-morbid MRS is more than or equal to 2, you see poor collaterals. Age is higher, more than or equal to 70. And then final decision has to be individualized, even if you encounter these subset of patients, considering families' financial, emotional, their acceptability of futile recanalization and long-term outcome. But still, we have a better future ahead. Long trials are coming up with better devices, government coming up with better plans in supporting stroke care in the current scenario, and we have a better future ahead. Thank you so much.
Thank you. Thank you, Dr. Piyush. That was a very good debate. I think both Dr. Bobby and Dr. Piyush went on in detail with regard to the debate. Dr. Bobby mentioned about relatively taking most of the patients into consideration for endovascular thrombectomy. And Dr. Piyush was very clear that we should not be taking up patients who are more than 70 years, poor collaterals, aspects less than 3, and the patient's financial aspects. So he was highlighting on the point of financial aspect should be a major decision point in making a decision of giving thrombectomy for large core patients. So we'll have just 1 minute for a rebuttal. Dr. Bobby, and then we'll go to the panelists.
So just a quick rebuttal. Piyush, thank you for your views. Just that sometimes, most of the time in acute situation,
Bobby, can you be a bit closer? It's not clear.
Can you hear me now, ma'am?
Yes, this is better.
So even trials, or analysis of data has shown that patients' families do not actually wish to hear our estimates of probability. They would rather that we attend to their loved ones in an emergency, even if there is only a slim chance of neurological improvement. And even the Satin study has shown that experienced neurointerventionists were accurate in predicting outcome only in less than 44% of the time. That means we are most of the time overly pessimistic when sometimes outcomes are better than expected. And also with medical legal practice, it is seen that the majority of malpractice lawsuits are related with alleging a failure to treat. So if you look at the earlier trials, the earlier studies in 2019, you can find that most patients went to court with an allegation of failure to treat with acute ischemic stroke with TPA. and it was less, there was less of a chance to go for a case against a doctor when he failed to offer thrombectomy in LVO. But in 2023, now the scenario is slowly changing, especially with the new trials. The number of malpractice allegations and lawsuits in the US, which is always a bellwether and a benchmark, are going up. And now it is seen that most of these lawsuits are rather for a failure to treat or a delay in treatment as opposed to complications. So patients in the initial part, at least, always expect us, even if we commit error of commission, it is still better than error of omission and not offering based upon different circumstances. It's up to the patient to decide, but we must offer endovascular thrombectomy for all patients with large. Thanks very much.
Thank you. Thank you, Dr. Bobby, I think Bobby was expecting this financial aspect to come up. So Bobby was very well prepared for that. Dr. Piyush?
Yeah. Thank you so much, Dr. Bobby. So I agree with you. Like I said, I agree, but I disagree. So by agreeing, it should be offered, but we should be, I'm not saying that we should be pessimistic about what we counsel the patient, but there should be a realistic discussion with the patients. Like in the scenario one, if the patient is a well-to-do family, if they have a realistic expectations of the cost of the procedure, post-stroke management, and the long-term rehab associated with, we should definitely go ahead with the treatment. There is no doubt about that. I would do the same. But those subset of patients are too little. The majority of the patients, they need to be really counseled regarding the possible outcomes, because in the current scenario, like what we face in daily lives is, once you offer the treatment, the patient is always thinking that my patient is, the family is always thinking that my patient is going to get better. If you offer them realistic goals, if they are fine with it, I would go ahead with it. But still, I'll be very cautious in the subset of patients that I've talked to you about. Thank you.
Thank you. Thank you, Dr. Piyush. I think, Dr. Rathod, we'll have the poll and then we'll go to the experts.
Yes, ma'am. So we can have a poll now, and let us see if there's anything in changes in the perception. So the same question, and I request all the delegates to please vote for this question.
So should endovascular thrombectomy be done in all patients with large core? Yes. No. So I think currently it should not be. What is large core should be taken off. So should be done. Why debate?
So I hope that what is large core will receive 0 vote now. Okay, we can show the results.
Okay, so that's a big difference. Okay, so now, so that is a fantastic debate, and it could make a, no, I think it's a realistic thinking process which comes in when it comes to medical management in patients, and you think always in an individualized manner. So now I want to hear from the real expert, Dr. Kaul. So for your comments, please.
Can you hear me? Am I audible?
Yes, sir. Yes, sir.
Okay. The first thing I want to say is that both the debaters have done exceptionally well. That should be underlined. Both of them, Bobby and Piyush, they have done what they were expected to do. You know, they have supported their argument, and actually both of them are saying by and large the same thing. All of us are basically saying the same thing. We are all in resonance. We know the situation, but we are going to the extremes because that is what a debate is about. And don't even go by the final polling and all that may not reflect the actual truth, what the polls say. Truth is only what happens in that to that individual patient, right? Now, this whole thing starts basically from dawn and diffuse trial. And if you see in diffuse trial, which is up to 16 hours, they are allowing you to thrombolize if the core is up to 70. After 16 hours, suddenly that window shrinks. After 16 hours, you have to then, with each passing hour, the window, the core shrinks and shrinks and shrinks. And by 24 hours, it's hardly, I think, 10 cc or something. So in that scenario, most of the patients are getting excluded. So now when we have this kind of a very, very energetic and a very enthusiastic travel where they're allowing you to thrombolize all patients. It's a very positive thing. It's a very positive, very loud thinking, very enthusiastic thinking. But at the same time, they are not assuring the good outcome in every patient. They are not assuring that. They are saying there may be some 20% difference. Now, what does this 20% difference mean? What does the 20% difference mean? It means that if there are 100 patients, you do thrombectomy in 100 patients at 22 hours, maybe 10 or 15 of them will become normal, but 85% will not become normal. This is how we have to explain to patient. Look, but it is your luck now. Because doctor is not taking any role in this. He is giving it to the patient for the fear of medical legal person. Doctor is trying to save himself, not the patient. So I think in this, we need some more. I would need some more data because I also know, and I'm sure Bobby also knows, that if at 23 hours he gives it to everybody, 80% will not do well because the data is like that. 20% may do well. Who are those 20%? We yet are waiting for the data. I would want to know the data. What happened? 0 to 3, we know that it will not work. But all of us are agreed. Now, between 3 and 5 is a big spectrum. I would want to know how are those who are doing at 5, how are those who are doing at 4, how are those who are doing at 3. And based on that, I will take the decision for the patient. I will not tell them I have to do it in you. It has, look at what is our topic today. Our topic is very easy. It is saying it should be done in all patients, not even offered. It has to be done. That if the patient comes and you just do the thrombectomy. No, that cannot be the case. But I will agree that it should be offered to all the patients after explaining to him that, look, 80% chances he may remain same, 10% chances he may worsen, but 20% chances, then it depends whether he takes it or not. You know, this morning I went for a dental implant. One of the tooth is giving me problem. And my dentist told me, Dr. Kaul, 20% chance of success is there, but 80% is this implant will not stay. Will you take it or not? But your money will still go, 30,000, 40,000 rupees. I said, I will take the chance because I can afford 40,000 rupees. But I'm sure if there is somebody else, he'll say, no, yaar, if 80% chances it will not, then I will not do it. So therefore, I think it has to be personalized, Shailja. In my opinion, it has to be personalized. You know, they have tried this, this general thing so they tried polypill for secondary prevention of stroke. You know, polypill is a very funny concept. And even now, that means in everybody who is more than the age of 50 years, give him aspirin, give him lipids, give him diabetic treatment also. It didn't work. It can't work, right? So that is one thing. And even in heparin story is the same. Why did heparin fail? Because in 60s, everybody used to get heparin. I'm sure there are some patients who do extremely well with heparin. I have seen them. Recurrent TIAs, thrombus. But when they give heparin to everybody, it failed. Now it is even out of the guidelines. Now, one of the things which somehow you did not quote, there's a recent study called Tesla study. It has recently come. And what Tesla study did is that they did not use the CT perfusion data and all. They just did a simple, it was presented in the European Stroke Organization, ESO meeting. In that they did that is the latest in this field as far as the trial is concerned. They did a simple non-contra CT scan. And they found there's a trend for improvement in large core. They found a trend, but it was not statistically significant. But they found a trend. So the point is we have to be finally realistic and finally pragmatic. You have to make some idea whether this patient is likely to do well or not. Explain to patient, and if the patient, sometimes it's very difficult, as Bobby also said, it's very difficult to predict. 44% people were wrong. So it's very difficult to predict, but just tell him whether he wants to take a chance or not. If he wants to take a chance, but you know, some people don't take a chance. They tell doctor, you only think for us. Doctor, what most of our patients say, doctor, you only think. How do I know? And they're right. At that time, we have to make this judgment based on the available data, age, collaterals, and all, rather than just going in and again, finance thing also you have to take into consideration. That is all my overall opinion about this, but I like to hear from others also.
Thank you, sir. I think as sir has already mentioned, we are all in the same boat.
Yeah.
We all think we take the evidence to make our decisions, but finally it is like we take every aspects into consideration for the patient. And we probably even look at the patient to see, after talking to them, we get a perspective of how the patient and the family is. And then we support them in the decision making. Dr. Gigi?
Yeah, I am very, very happy to hear this. Till recently, the concept was beyond till after 6 hours, no thrombectomy. If you see a large infarct, no thrombectomy. At least these debates have brought in a feeling that the thrombectomy can be offered as a
Yes,
solution.
yes.
I say that it should be considered and offered. Nobody will do thrombectomy in all patients coming up to 24 hours. You should imagine that if I go in the middle of the night and make a patient spend 3 or 4 lakhs, and if the patient doesn't improve or deteriorate or have a complication, it's not a good thing for me also. I mean, that brings in the point that the role of the stroke neurologist in this situation is very, very important in taking all these things into consideration, the collaterals, like that is the most important single deciding factor which decides the outcome. But the best thing is there is definitely a subset of patients who will benefit.
Yeah.
So we have to identify them and then have a discussion with the relatives. It should not be a hard and fast rule that there are patients definitely who are not going to improve. Bobby, everybody will agree with that. Large core, and the collaterals are bad with an ICU occlusion. The collaterals are bad. Everybody knows that those patients are not going to do well. So, but the problem is we have only one chance to treat this patient. And it is like a death sentence, you give at that time. So many things come to our mind. Suppose if you don't offer the treatment and later he goes to somebody else and they say that, it should have been done at that time, then we are in the soup. That is something, like you're telling that it should not be done. So we have to, everybody will have their own tactics of dealing with this situation, considering the facts. Like as a certain, sometimes they tell that, suppose if it's your father, what would you do? So if my mind tells me that he is unlikely to improve, I'll say that I can't take that decision on your behalf, but probably these are the situations. But sometimes I feel that MRS 6 is better than MRS 5.
Yes. Yes.
Yeah, because so it has to be a decision, but contrary to the expectation, less than 6 hours, you do a thrombectomy, next day the patient is up and normal. That is the one which we all share in social media and LinkedIn. But these are patients after 6 hours, they don't improve that fast. But what I've seen is that at the end of 3 months, they do very well. So that is very convincing that these two patients do very well so end of the day, my take home point is this should be considered, even if there is an infarct coming after 6 hours, this should be considered,
Correct.
Offered and discussed with the relatives. That you don't have, there should not be a expectation which is dramatic. Tomorrow he is not going to sit up and start talking and move around. And it should be a very realistic discussion and then take a decision. They shouldn't complain saying that you did not consider, you should not. We shouldn't categorically say that no, this is not for thrombectomy. That is my take home point. But there is a welcome change that the indications for thrombectomy is opening up. People are, so the role of the decision maker, the clinician in this setting becomes even more important. So consider all these things and take an appropriate decision. I'm very happy, Bobby and Piyush, you have done an excellent job, like fantastic review of all the literature available. Bobby, your concluding remarks, both of you have done very well as a debate.
I think, Shalja, can I take only 1 minute?
Yes, sir.
Yeah. No. I think as Gigi says, we are completely agreeing. Nobody is debating against anybody here. We are all agreeing with each other. We know that. Only to bring out the points we are saying. Gigi, there's also a very interesting discussion happening on these days, not only about the size of the core, but the composition of the core. There may be some part of core which may be reversible also. So therefore, maybe it is those patients who may show. 10 years back, there was a lot of enthusiasm about that. Shailaja must be knowing that this diffusion abnormality does not mean that some of the diffusion is reversible. Somehow, over the course of time, people forgot about that and that discussion stopped. But I think this will bring up the discussion again, that what we think is a large core, some of it may still be reversible. You never know. So we really need more data, more thing. But in the meantime, as he said, it should be offered, not necessarily done in every way. Okay.
Thank you, sir. Before I tell the concluding remarks, there are 2 questions, in fact, in the
Madam, can I?
Yes.
So, no, so as a non-stroke neurologist, what I gathered is that it is to all the panelists as well as the participants. So what I understand that if within 6 hours, irrespective of whatever the core size or anything, we have to do mechanical thrombectomy. So that is the one thing. Is that correct, or this large course?
No.
No, that's not correct. That's
No,
not correct.
That's not correct. No.
So this large core concept applies to even within the less than 6
Within
hours.
the 6
period
hours,
also.
Yes.
Okay, so we are not talking of this window period of 6 hours and this, irrespective of what is the time duration, the large core concept remains the same.
It is 0 to 24 hours.
Okay, so that to clarify, because when Gigi sir was mentioning, I got a bit confused that this less than 6 hours, irrespective of the core size, we might have to do. So secondly, what I understood that if it is between less than maybe less from 4 to 6 aspect score, or with a good collaterals, obviously they are good candidate and the EVT should be offered, and I think everybody will offer. But what about those patients if that aspect is let's say 0 to 3 and or they have a poor correlator? So we should not offer in that. That is yes and no question.
There is a debate there.
Yes.
Yes. So those are the areas where, as we discussed in detail, that where we don't have an answer, probably we may have to wait for more data to conclusively talk about those areas.
But what do you do as a suppose let us say a patient is fully affording and patient understands the everything and all these outcomes. So the scenario of a aspect, let's say between 0 to 3 or 0 to 4. And so I think you will offer a
Yes, yes. I think it has to be very individualized, Rathor, with regard to the decision in those patients, in the borderline patients, no? I think it should be an individualized decision of looking at the collaterals. So that is how this data is useful. So for example, when you're talking about aspects of 2 with a poor collateral and a 70-year-old man or with an ICU occlusion, these are the patients we are invariably not wanting to take them, but we will still talk to them. And most of the time, the decision of the patients will also depend upon how we tell them regarding the outcome. Most of the decisions are made by the doctors.
And
I
from
always believe as a counselor, you can shift the decision.
Yes.
Exactly.
For epilepsy surgery, if I have to counsel, I can counsel them in that 2 different ways.
And many times it depends on what the cousin from America is calling them and telling them.
Yeah, right. Exactly. So if you don't want to do, no, confuse them. So that they don't take that decision. So what I always tell my fellows is that the collaterals is the time window is going out. So there might be a subset of patients where the collaterals are very good now. That is like an ambu bag, keeping the tissues alive. So any end of the day, I would like to see a vessel which is open, which gives them the maximum chance of recovery.
So one last question. If there is a low aspect, that is 0 to 3 and good collateral, so you will still go for it?
Most of the time, they don't go in line, Rathor.
Yes.
So within 24 hours, if you have a good collateral, it's very unlikely to see a patient with an aspects of
Correct.
0 to 2.
Correct. That combination doesn't exist.
Okay.
So I think there are 2 questions, Rathor, but I think both the 2 questions, when I read through, it's already been answered. One is regarding the government support. The Ayushman Bharat it said that it is going to, we were actually in one of the meeting, and it is going to be, the package amount is going to be increased. So probably we may have a better chance of offering more financial assistance to the patients. And I think, first of all, I should thank both the speakers for the fantastic debate. We brought in all the minute aspects of decision-making, going in detail through the trials and even the financial aspect of how sometimes your decision-making, you may retrospectively go back and see that maybe we should have done, or sometimes maybe we should not have done. So that's how the medical planning, or you make your decision. And thanks to both of you. Thanks to Dr. Kaul, as usual, bringing in all the aspects of how you realistically are in a position as a stroke neurologist and how difficult it is to make a decision for the patient. Thanks a lot. So it's very important that how each of us think when it comes to a patient. We all think in a very different way. And Gigi, as usual, Gigi, one point I want to tell in this venue is, Gigi was one person, even before all the trials came. I still remember Gigi was one person who put in our stroke WhatsApp group of a patient with an aspects of 4, where he did a large core thrombectomy and the patient did relatively well. Hope, Gigi, you remember at that time we were all thinking, oh, it's not guidelines, it's not in the guidelines, how confident can we be? So thanks, Gigi. So finally what we think may finally come up as a guideline too.
Oh.
And for all the participants, so from what we can conclude is that the decision of large core thrombectomy has to be very individualized, because we are offering a treatment which is very expensive. And if it fails, it is going to be a decision of a very important decision of how it is going to be a long-term disability for the patient and a drain of the financial resources. But at the same point, we know in select situations, this is going to be very effective. And for those patients whom we feel are likely to benefit, the data which is available from the RCT, as Gigi was mentioning, we should definitely go ahead and open the vessel and see whether the patient benefits or not. And thanks to INTAS for all the support for this webinar. And in fact, we all learned a lot with regard to how we think about in an individual scenario for a patient when we are managing patients with endovascular thrombectomy when they have a large core. Thank you. Any more?
We have the last poll once again. Maybe the final poll. So now after the consensus, is there any change? Can we launch the poll, please? Now the number of participants are reduced, so that will be a bit biased results. Let us see. So the same question, and I request everyone to answer that. Okay. We can show the results.
Okay, so it has made a change. Okay.
Not much
That's
change.
No, but that big difference has come down. Yes.
Okay, but still, as it has to be individual like that.
Yes.
Okay. Thank you, madam, for moderating the session. Thank you very much, and thank you all the panelists, expert panelists, and speaker for that. If Mr. D'Souza from the INTAS, if you want to give a vote of thanks, maybe last few words for your logistic support. Thank you.
Thank you very much. Good evening, doctors. I would like to begin by thanking the speakers, both Dr. Bobby Varkey and Dr. Piyush, for so lucidly presenting their wholesome views for and against this topic. The endovascular thrombectomy should be done in all patients with large core. I would also like to thank the expert panelists, Dr. Subhash Kaul and Dr. Gigi Kurukulam, both experts in the field of stroke, for sharing their wealth of clinical experience on the topic to make this program an enriching one. I too wish to thank Dr. Madam Shailaja for so gracefully moderating this program by summing up the critical points, take-home messages for the benefit of one and all. Last but not least, I wish to thank Dr. Chaturbhuj Rathod for being the driving force in organizing today's program for the benefit of medical fraternity at large. Thank you all the attendants for today's program for making it a grand success. And I wish to remind that we have this program every month on the second Friday of every month. Thank you very much, and good night to all of you. Thank you.
Thank you so much. Thank you.
Thank you, everyone. Thank you very much.
Thank you so much.